Assalamu alaikum. Good morning, good afternoon, good evening. I hope everybody is doing great. I know a lot of IMGs are joining from different time zones, so that's why I'm trying to make sure that I cover everybody. That's why I say good morning, good afternoon, and good evening. So today's lecture is about sepsis, very commonly tested, very high yield, and one of the most commonly topics tested in the licensing exam. So sepsis and septic shock. Today we're going to talk about the recognition, definitions, and initial management, which is very high yield in the licensing exam. So what is sepsis? Sepsis is, I'm pretty sure everybody by now knows it, life-threatening organ dysfunction caused by dysregulated host response to infection. Operationally, acute increase in SOFA score of 2 points or more from the baseline. Sorry. Assume 0, F, and none. Overall mortality is 10%. So we will talk about SOFA score if you have a question, and which I'm pretty sure you will. So we will talk about it in details. And also when we are doing some cases, during doing cases, you will have a few cases that you need to use SOFA. So that way it will be much more easier to understand it than me explaining it to you. Septic shock. Septic shock is the subset of sepsis with profound circulatory and cellular metabolic abnormalities. So the difference between sepsis and septic shock is for the septic shock, you have a persistent hypotension despite using vasopressor to maintain the MPA or main arterial pressure 65 and above. So it means once you have the organ dysfunction, you have the shock. Once you have the organ involvement and failure, you have shock. Okay, so persistent hypotension despite using the vasopressor and the main arterial pressure is 65 and above. And not only that, lactate, which is another important factor to remember, is greater than 2 while you're using the vasopressor. Canadian sepsis pathway commonly use lactate as a resuscitation target, aiming for improvement with the fluids, vasopressor, and source control. Remeasuring lactate within the first hours helps confirm whether the perfusion is improving or whether this escalation should happen, like vasopressor ICO is needed. So basically, sepsis, when you have infection, you have sepsis, the body starts to react, you have sepsis. And for the sepsis, if you are suspecting, then you have to do the SOFA. So again, we're going to talk about it in details. So the mortality, why sepsis is very important, the mortality is 10%. What is septic shock? When we have sepsis, but not only sepsis, we have organ involvement, vital organs involvement, whether it is the CNS, whether it is the cardiovascular system, whether it is the coagulation abnormality, whether it is the respiratory abnormality or dysfunction, whether it is liver involvement, or whether it is renal involvement. So one of these organs will be involved. Not only that, in a shock, you have for the sepsis, you use the hydration antibiotic, the patient gets better. But for the shock, usually you need the vasopressor to maintain the main arterial pressure above 65 and lactate usually be 2, greater than 2. So this is the most important thing, again, that it might be in the licensing exam will be the lactate, remeasuring lactate. So it means if you have shock, a person who has septic shock, and when you start treating the patient, then you have to measure the lactate every few hours to see if the patient is improving or you need to escalate the treatment or reconsider your treatment approach. Okay, that might be in the exam. So remember, if you have a septic shock patient and you start the treatment for monitoring the patient to see if your patient is improving or the patient is getting worse, you need to check the lactate every few hours. For the example, to make it very short, sepsis requires infection plus organ dysfunction. Septic shock requires vasopressor to maintain the main arterial pressure over 65 and lactate more than 2 after fluid. And we have a wrap up at the end. I will wrap it up for you at the end and give you a snapshot of definition about the septic shock, sepsis, and also systemic illness. So the clinical impact, usually, as I mentioned before, the mortality rate is around 10%. So major driver for the ICU morbidity and mortality through organ dysfunction. Progression can be rapid. Early treatment reduce risk of shock and multi-organ failure. So we need to engage as soon as possible. If you suspect, start the treatment. But it doesn't mean that you have to just skip the culture. No, take the culture, but usually we do how many cultures? We do 2. So do 2 cultures and start the treatment, even if you're suspecting that my patient might have meningitis. You need to start the treatment first, I mean the antibiotic, then if you have to do the lumbar puncture, you can do the lumbar puncture. So do not delay the antibiotic for doing the lumbar puncture, okay? So management prioritize parallel action, resuscitation, antimicrobial, and source control. Source control is also very important. When you have a septic shock or sepsis, let's say septic shock, you have a patient, you start the antibiotic. Now, you start the antibiotic, you need to find the source. If the patient has abscess, the antibiotic on its own is not going to do any good for the patient. You might lose the patient. It will help, but it's not going to take care of everything on its own. So you need to do like drainage to help with the antibiotic. So they are kind of combination. So it means that you start antibiotic, it is not, your job is not finished yet. You have to go after the source. What is the source? Whether it is an abscess, whether it is, for example, catheter, whatever it is, you have to remove it. You have to go take care of the source as well. But at the same time, start the antibiotic first. Okay? So pathophysiology, dysregulated host response leads to widespread inflammation, vasodilation, and capillary leak, reduce the effectiveness or effective circulating volume, microcirculatory and cellular dysfunction, impair oxygen utilization, result tissue hyperperfusion, lactate elevation, and organ failure. So the most important thing we need to remember about the pathophysiology, that if we do not start the treatment as soon as possible, the patient will have multi-vital organ failure and the patient will die. Now, the SOFA 3 criteria, this is, we call it a rapid bedside screening. For somebody that you're suspecting sepsis, this is the rapid bedside screening. So what do we do? Respiratory. Rate 22 or higher. Alter mental status, if it is less than 15, it is affected. So if you see mentation, that means alter mental status or mental status. Systolic pressure usually less than 100. Interpretation, if the patient scores 2 or more, it means the outcome is poor and warrant urgent evaluation. So if it gets 2 or more than 2, it means the patient has organ dysfunction and the outcome is poor. So I have tips in sepsis-related ARDS, acute respiratory distress syndrome. Prioritize the lung protective ventilation with a low tidal volume and controlled pressure. If you notice in my line, the last part is bold. That is going to be in the exam. In the exam, they will give you a scenario about somebody who has ARDS, and now the patient has sign and symptom of septic shock or sepsis. And the next step is, how do you go about it? In sepsis-related ARDS, prioritize lung protective ventilation with the what? Low tidal volumes and controlled pressure. That would be your answer. I'm not saying that it will 100% be in the exam, but it's most likely if they give you a scenario of sepsis secondary to respiration infection or upper respiratory tract infection or lower respiratory tract infection, it will be tested very commonly. The low tidal volume and controlled pressure, very commonly tested. Okay. I'm emphasizing on the points that might be in the exam, whether it is going to be a simulation exam, whether it's going to be any type of exam. So there is high chance of those points that you need to take a note. Clinical implication, when the Q SOFA is 2 or more than 2, again, what is the next step? We have to evaluate for organ dysfunction. How do we do that? We have to do the SOFA concept. Measure lactate and assess perfusion. Start parallel management. While you're doing this too, you need to do the antibiotic. I mean, you need to start the antibiotic, you need to start the fluid and the source evaluation. Okay. So persisting instability after fluid and antibiotic is a strong signal that definitive source control is needed. Like you start the antibiotic, the patient is not improving. Usually, remember this, that if you have a patient, especially if your patient is in the hospital, you start the IV antibiotic, the patient has to improve within 24 to 72 hours. If the patient is not improving within 24 to 72 hours, it means you need to reconsider the diagnosis or reconsider the way that you are approaching the patient. Probably you're using the wrong antibiotic, or probably you're treating completely wrong condition, right? But in the meantime, you should see some difference. It doesn't mean the patient is going to be all well within 72 hours or 24 hours, but you can see the patient is improving. The patient is getting better. The fever is dropping and the respiration is getting better, right? Not all the way, but at least it's getting better than a few hours before. So the patient is not as bad as before. If the patient is not getting better, it means there is something going on that I need to go and find. For example, you need to find the source of the infection. MCQ1 commonly tests the drainage is not elective in obstructive urosepsis. It is life-saving. And if you notice, I made it red and I made it bold. Why? Most commonly tested. When it comes to urosepsis, they want to test you if you know that the drainage is not only a best treatment option on top of using the antibiotic, it's life-saving. Okay? Write it down. Hemodialysis, catheter-related sepsis requires empiric coverage for likely pathogens, including the MRSA and gram-negative organism. So if you have somebody, your person or your patient is suffering from some sort of chronic kidney disease, renal failure, and he is getting hemodialysis, and the patient has sepsis. So they might ask you which type of antibiotic are you going with. Again, this is also, I'm not saying is as commonly tested as urosepsis, but it could be a question. So you need to know that you need to find an empiric coverage for something that covers the MRSA and gram-negative. Safety note, low Q SOFA does not exclude sepsis, treat based on the clinical consent. So we know that if my patient, when I do the quick bedside screening, if it is 2 or more than 2, I know the patient has an issue that I need to do and check for the organ dysfunction. I need to go after SOFA, doing SOFA, right? But what if it is 1? If it is 1 and you're still suspecting that my patient has all sign and symptom of sepsis, but Q SOFA is 1, it's not 2, it's not 3. So if it is 1, it does not automatically rule out sepsis. It means that you need to do more or further investigation. Okay? So sixth system that's supposed to be assessed. What I do to make it very simple for you guys, it has 3C, 2R, and 1L. CNS, cardiovascular, coagulation, renal, respiratory, liver. So I think this way you can memorize it. 3C, 2R, 1L. What is 3C? CNS, right? Cardiovascular, coagulation, renal, respiratory system, and liver. So typical variable used in practice. These are the things that you need to check. So the PaO2 and this ratio, the platelet count, why we are going after the platelet, because patient with the sepsis is at risk of septic emboli, right? And bilirubin, why? Because of liver, right? Main arterial pressure, because we need to know if the patient is getting worse or better. And if we need vasopressor to maintain it above 65. Glascoma scale for mental status. Creatinine and urine output for renal function, because that's a vital organ that we need to look after. So baseline SOFA is assumed to be 0 if no pre-existing organ dysfunction is known. Now the algorithm, if you're suspecting infection by history, exam, vitals, risk factor, start monitoring. So the next step will be do the quick bedside screening, which is the Q-SOFA at bedside. If it is high risk, if the patient is high risk, assess organ dysfunction. How do I do that? I do it with SOFA concept. If SIPS is positive, the SOFA will increase 2 or more than 2. That will confirm the organ dysfunction. So I have someone, my patient has all signs and symptoms of sepsis. And how do I know that? Because I took history, I did the physical examination, and I know the risk factors. So what should I do now? I have to do a Q-SOFA. Now for Q-SOFA, the patient is very high risk for the sepsis. My next step is to do SOFA. So for SOFA, if it is 2 or more than 2, it means the patient has organ dysfunction. For the Q-SOFA, the patient, I'm not sure if the patient has organ dysfunction. If it is 2 or more than 2, now the patient has organ dysfunction. So determine septic shock after adequate fluid. So you have a patient who has septic shock. And if the patient is not improving, you started the fluid, you started the antibiotic, which I do have the step-by-step treatment. Probably it will be in this one of these slides. I will definitely walk you guys through that as well. So if you have this and you start the antibiotic and the fluid, it is not improving, then you start the vasopressor. If vasopressor doesn't help, then you go after vasopressin. If that doesn't help, then you go after epinephrine. And also, the last resort will be a steroid, but there is a very fine line between using a steroid and epinephrine, which we will discuss it. So the criteria is vasopressin needed to keep the mean arterial pressure 65 and above, and the lactate 2 and above. So this is septic shock. If you have somebody who has septic shock, that he requires to use vasopressor to at least maintain the main arterial pressure above 65 and lactate more than 2, this is septic shock. Action bundle, what do we do? Again, antibiotic, fluid, and vasopressor. We don't start vasopressor right away. If the antibiotic and fluid doesn't help, the next option will be vasopressor. Lactate trending, every few hours we are checking. Why? To monitor our patient if the patient is getting better or I have to escalate the treatment. Source control, we go after the source, ICU level monitoring. So this is from the Toronto notes, which I love it. I'm pretty sure you guys have access to the Toronto note. I'll let you guys to go through this on your own, but it's basically the same thing that I summarized it. So first action, start, do not sequence. So what do we do if we have someone with the sepsis? The immediate management priorities, key intervention should begin as soon as possible as sepsis recognized. So do not delay your treatment. ABC, right? So start with the airway and oxygen, escalate if fails. Establish IV access. Measure lactate, repeat if elevated. Obtain blood culture and relevant specimen, no significant delay. Remember that how many culture do we do? 2. There might be a question, how many culture do you do? 2. And also for infective endocarditis, how many culture do you do? 3. So for this one, for sepsis, usually we do 2. Okay, so start effective broad spectrum IV antibiotic. We usually started with the broad. Remember, we start with the broad antibiotic until we get the result of the culture. Once we receive the culture and I know that it is specifically gram-negative Staphylococcus aureus, then I go after cefazolin or something that's more sensitive to that type of infection. Okay, but you need to start it as an empiric broad antibiotic. And begin fluid resuscitation for hypotension or hypoperfusion. Note, blood culture is typically prioritized in unstable patient. If the patient is unstable, prioritize the culture first, which we always usually do this, right? Even if the patient is stable, we have to, if we suspect, we need to do the culture, but for unstable, that's the first thing you need to do and move on after that. If hypotension persists after fluid, start vasopressin. As I mentioned before, we start the fluid antibiotic, and if it fails, then we go after vasopressin. So the first line that we choose is norepinephrine. Target the main arterial pressure 65 and above. Reassess the mental status, urine output, because oliguria happens, lactate trending for making sure if my patient is getting better or worse. Arrange urgent source control when indicated. We did talk about this. Escalate to ICU level care early for shock or organ failure. Perfusion targets practical. So these are the things that we have to memorize it. We have no other choice. The main arterial pressure, it has to be 65 and above. Urine output 0.5 ml per kg per hour or higher. Implementation and prefer perfusion. Lactate improving toward normal when elevated. Vasopressor. So this is important. If you notice, I made it 2 different colors, 3 actually, 3 different colors. So they will be in the licensing exam. I'm not saying like 100%, but most likely it will be in the licensing exam. So what they do, they want to test you that in a specific stage of sepsis, do you know which one comes first? And if it doesn't help or it fails, how do you go about the patient? What is your second best option? If things get worse, what do you do after that? Or if the patient's heart is not pumping as much, then what do you do then? Okay. So first line, let's say you started the IV, you started antibiotic, your patient is not improving. Now you start the norepinephrine, the vasopressor. It doesn't help, vasopressin. Remember, vasopressin comes after vasopressor. And consider inotrope if the patient has low cardiac output. Usually, they give you a scenario of a person that who has sepsis, the patient has been on IV, the patient has been on vasopressor, and now the patient has output dysfunction. What is the next best step? Then you go after dobutamine. So high yield PET falls. These are the things that you need to avoid. That's a no-no. So these are also very high yield that you, in the licensing exam, that you have to keep in mind to avoid it. For example, do not delay vasopressor in a persistent hypotension after adequate fluids. If the patient starts IV fluid not improving, then don't delay, start it. Okay? Because the more you delay, the worse the patient gets, and the sooner the renal failure will happen. Avoid unbounded fluid bolus. Reassess fluid responsiveness frequently. Dopamine is generally avoided due to higher arrhythmia. Why? Because our patient will have arrhythmia. And if you give him dopamine, it's going to make it even worse. Treat the cause. Antibiotic and source control are essential to reverse shock. Diagnostics that should not delay care. Culture, we do not, we do the culture, but it should not delay my care. I have to start it. But usually we start the antibiotic, we do the culture and then start the antibiotic. And then if we need to do the lumbar puncture, we do the lumbar puncture. But remember, if you don't have time, you don't have to delay it. I mean, delay the treatment because of the culture. Imaging. Do not delay the treatment for imaging. Remember that mortality is 10%. So the sooner you start the treatment, the more the chances of survival. Repeat assessment. And I mentioned this, that we have to keep reassessing the patient. At the same time, we have to keep rechecking the lactate. Principle, start treatment first when unstable, refine once evidence accumulates. And source control and antibiotic refinement. Source control when appropriate, drain abscess, debridement necrosis, and remove infected device if it is catheter, right? Relieve obstruction if there is an obstruction, reassess antibiotic daily. And once you have the specific or sensitive antibiotic, then de-escalate to the targeted therapy based on susceptibility. As I mentioned before, that you need to start with a broad spectrum antibiotic. Once you receive the culture, this is very sensitive organism to cefazolin, then you don't have to use and bombard the patient with antibiotic. Just go after that and a specific antibiotic, let's say it's cefazolin, amoxicillin, whatever it is, right? So use shortest effective duration for source. Respiratory and nutrition, oxygen and ventilation support as needed. Use lung protective ventilation when ventilated. Remember, low tidal volume strategy. Remember this. They might test you on this one. Early eternal nutrition when feasible to support gut barrier function. Avoid excess sedation. Reassess readiness for the liberation. Avoid excessive sedation. I mean, they're already suffering from too much issues already. So we don't want to decrease the respiration rate as well. So prevention and communication, these are the things that we need to know for prevention, like if VTE prophylaxis when bleeding risk allows. Glycemic management, avoid severe hypoglycemia and hypoglycemia. Pressure injuries, prevention and early mobilization when feasible. Early goals of care discussion and patients with patients and family. So these are the things that we need to look after and prevent. So these are not very commonly tested, and I don't want you to waste your time. So we're going to skip this. And I doubt it if they're going to have it in the licensing exam. So the systemic review shows possible small mortality. Okay, practical MCQ1 framing, consider IV. So this one, now since we are talking about hydrocortisone, now I would like to give you the difference between choosing the epinephrine and steroid. So we all know that we start with IV fluid, antibiotic. So if the IV fluid is started and the patient is not improving, especially the hypotension is not improving, we need to escalate it to vasopressor. Still, if the patient is not improving, despite vasopressor, we add vasopressin. So let's say now the patient, despite using vasopressor and vasopressin not improving. Now you have two options. You have two options. One option, should I use a steroid? Should I use epinephrine? There's a very fine line. Now, the fine line is that if my patient is getting worse, I go after epinephrine. Let's say my patient is taking vasopressor and vasopressin, but the main arterial pressure is going down. It is not 65, it is 60. The next day it is 59. The next day it is 58. I have to start epinephrine. And it's just an example to make sure that you guys understand. Now for a steroid, same scenario, but my patient is dependent to vasopressor. So if the patient takes vasopressor, the MAP or main arterial pressure is maintained within the normal range, which is 65 and above. When he stops vasopressin, it goes worse. But when he starts it, it gets better again. Same thing with lactate. When he stops it, the lactate goes up. But when he started, it goes down. Okay? So same thing. For this patient, I'm going to use a steroid. Now, again, I know it's a little bit confusing, but it really depends on dependency of patient to vasopressor to maintain the main arterial pressure and lactate. If it is vasopressor dependency, use a steroid. If the patient, despite vasopressor and vasopressin getting worse and worse and worse, start epinephrine. I hope it makes sense. All right, so don't miss. Sepsis equals suspected infection plus acute organ dysfunction. So sepsis equals to suspect infection plus acute organ dysfunction, SOFA concept. Septic shock equals vasopressor. I think we did talk about these stuff, so I'm not gonna repeat myself. Start antibiotic early, do not delay it. We did talk about this as well. Common management traps. So unlimited fluid without reassessment leading to overload and hypoxemia. So it means that we shouldn't overload the patient with fluid. We know the patient needs it, but we should not overload the patient with fluid. It means we have to keep monitoring our patient. Delaying norepinephrine when hypotension persists after adequate fluid. Do not do that. Continuing overly broad antibiotics despite culture data. No de-escalation. Routine steroid or transfusion without appropriate indication. Remember, for transfusion, there might be a question. I'm going to pause here. I did talk about the steroid. I did talk about the culture. I did talk about the de-escalation of antibiotic. We haven't talked about transfusion. So for transfusion, the regular or the general formula is that if you have somebody whose hemoglobin is less than 7, then we can start the transfusion. But if you have someone who is severely ill, especially he has cardiovascular issue, for that patient, you need to start it even if it is 8 or 9. But for someone who is stable, septic but stable, they might trick you, because if somebody is severely ill, so you don't wait for this to go lower than 7, right? But they give you a picture of sepsis so that they confuse you, and you know, like, oh, this patient is septic, so I have to give him, and his hemoglobin is, let's say, it's 7.5 or 7.9. And then they give you an option of, do you have to do the transfusion? And one of the options is, yes, do it. And you are at the back of your mind, you're like, yeah, I know, severely ill, ICU, septic, and let's do that. The patient also needs transfusion. Let's do it. But if the patient is septic but stable, the patient is septic, you start the treatment, now the patient is stable, but hemoglobin is 7.8. You don't have to do it unless it is going lower than 7. But the same scenario, you have a patient who is septic and he has history of MI, or he has history of cardiovascular system. So in that case, I will start it regardless of the 7 or lower than 7. I have to keep it above 9 to 10. So within the range of 9 to 10, I have to keep the hemoglobin. Okay? Keep it in mind. This is how they're going to test you. Treat early, reassess often, and achieve source control. These 3 steps drive outcome and exam performance. Now, wrap up. Summary of triple S: sepsis, septic shock, and systemic illness. For sepsis, the definition, as we mentioned before at the beginning, it's a life-threatening organ dysfunction caused by dysregulated host response to infection. Remember, for sepsis, we have infection, right? For systemic illness, it could be infection, it could not be infection. In most cases, it could be a systemic issue. For example, an organ issue, okay? But it could be also infection. That's the difference between systemic illness and sepsis. Septic shock, yeah, I did cover sepsis. So septic shock, the definition, it's a subset of sepsis with a profound circulatory metabolic dysfunction, needs vasopressor to keep MAP or main arterial pressure 65 and above and lactate more than 2. The key idea: sepsis plus persistent hypotension requires pressure, often with the elevated lactate. This is septic shock. For systemic illness, definition is a broad term for a condition causing whole body physiological derangement. For example, the patient will have fever, tachycardia, hypotension, confusion, organ dysfunction due to infection or non-infection. Remember, for sepsis, infection. For systemic illness, it could be infectious or non-infectious cause. PE or pulmonary emboli, pancreatitis, adrenal crisis, thyroid storm, and if they want to test you on systemic illness, these are the most commonly topics that they want to test you. Pulmonary emboli, pancreatitis, more than that, thyroid storm, adrenal crisis, but usually pulmonary emboli out of all these 4, and thyroid storm. Okay? Key idea: sex systemically, infection not required. Like, you don't have to have infection to have a systemic illness. It could be infectious, it could be non-infectious. How to differentiate? Systemic illness, whole body illness, may not be infectious. Sepsis, systemic illness plus suspected confirmed infection plus organ dysfunction. Now, septic shock is sepsis plus fluid not enough, pressure needed for MAP plus lactate to be more than 65 and lactate more than 2. And thank you very much. And this is the end of our lecture.